Hello, everyone. My name is Adam Okada, Clinical Education Specialist with Healthmark, a getting a company. And it's that time of year again. That means it is SP Week 2025. And this year, we're bringing back our 7 days of CEs. And today, we're going to be looking at the top 10 issues to prepare your department for a sterile processing survey. Now, just some disclosures. I am an employee of Healthmark. No compensation's been received. Any opinions I give are my own and not that of my employer. And anytime I bring up products or anything like that, you really do need to look at the instructions for use from the manufacturers. And with that, let's go ahead and jump in. So, I want to tell you guys a little story, set the scene here. Just pretend it's Monday morning and you're rolling into the hospital. You're parking your car in the parking garage. You head inside, and inside the hospital lobby is always so beautiful and it's just gorgeous in the lobby. And then, of course, you head down to the basement where sterile processing usually is, and there's peeling paint and some of the ceiling tiles are coming apart. But you're going to change into your scrubs in the locker room, and this is actually a really nice locker room. I don't feel like most sterile processing departments get this level of fancy. I think more than likely you're in a closet that looks a little bit more like this. But kind of tight quarters, and you're all trying to fight for space in there. And then you hear over the loudspeaker, the hospital would like to welcome Joint Commission. And that always sets me into a panic. My response is always my neck gets tight and I start stressing out and my heart starts pounding, my blood pressure goes up. And ideally, what we want is when Joint Commission shows up, you're excited, you're calm, you have a sense of peace because you know your department is ready to go, ready for that survey. So let's jump into some of the issues we might see during survey time. Our objectives, we want to discuss the survey process and the training that surveyors go through to audit a sterile processing or endoscopy department, illustrate the most common findings in SP and endoscopy, and then demonstrate scenarios that will prompt more investigation by surveyors. We ideally want them to come in, we show them our process, and they make their notes, write things down, and then they leave. But sometimes we're going to have to get into a lot more investigation if there's things that are missing. So we'll get into those things as well. For objective one, we want to discuss that survey process. And a lot of people aren't aware that surveyors go through a tremendous amount of training before they come into a sterile processing department, not just on SPD knowledge, but they go through all the different departments of the hospital and have knowledge on really every part of it. So, just a little history lesson for those who don't know. This is Dr. Ernest Codman. Dr. Codman was famous for something called the end result idea, where essentially you would follow a patient until the end of their stay and then see what worked, what didn't work. And if the treatment was unsuccessful, you would try to find out why it was unsuccessful. And that's this idea of the end result. But in 1917, the ACS published a minimum standard for hospitals. Now, in 1917, that was a one-page document with a minimum standard for hospitals. By 1926, 9 years later, they had expanded that to 18 pages for a minimum standard for hospitals. And you can imagine if there was some kind of document like that where hospitals had to follow it today, that thing would be enormous, thousands and thousands of pages long, because there's so many different processes. But that's really the history of like where these standards and where the survey process comes from. This is a quote from Dr. Codman: the common sense notion that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view to preventing similar failures in the future. And really, that's going to get into later on down the line. This concept will lead into best practice, which is what we really want to shoot for in our facilities today. So the Joint Commission was founded in 1951. And again, it was founded on these ideas of best practice standards or minimum standards that hospitals should be shooting for. And I believe it was in 1960s, they actually started connecting to the insurance companies for reimbursement. So if you passed your survey, you were eligible for like Medicare reimbursement. But that one thing that people don't realize is that the Joint Commission didn't start doing unannounced surveys until 2006. So before that, they would schedule a time and you knew they were coming. Now it's a little bit trickier because you have to stay survey ready all the time, which I think is better. We really want to stay survey ready at all times. So this is taken from a Joint Commission webinar that was done in November of 2023 called A Day in the Life of a Joint Commission Surveyor. This is the people that are involved in being the surveyor. So there's doctors and surgeons, nurses, infection preventionists, respiratory therapists, and they listed that there were some other positions of people that had come in through the hospital system and then ended up at Joint Commission being a surveyor. As far as their training and what they go through, there is a new field rep orientation. So before they head out into the field, they're actually given this orientation period. Then they have a preceptorship where they go out with an existing surveyor to learn the process. They also have monthly training. They have assigned training modules on specific areas or tasks. And then they do rounding and check-in calls. So there's actually people that go and check on the surveyors to make sure that they know what they're doing. And then they have those check-in calls to see what the progress is and things like that. But a lot of training goes into being a Joint Commission surveyor, more than we think. And I think in the old days, there was this misconception that surveyors didn't know a lot about sterile processing. There aren't any specific sterile processing surveyors that came up specifically in sterile processing. Now, some of them do have experience perhaps managing it. Maybe they were a perioperative services manager, so they managed over sterile processing. But it's a misconception because nowadays they do have a lot of specific training and are really focused in the sterile processing and endoscopy areas because they know patient safety goals, infections have all come from those areas. What they're looking for, and they listed this, and it was really interesting to see. So I recommend if you're interested in how they do their process and everything, this webinar is a really good resource for you. But the Medicare and CMS requirements, that's their top tier. That's the thing they're really looking for, making sure you're hitting your minimum requirements. They also look heavily at the national patient safety goals. So if there's something patient safety related that's come up in the last year, they really focus on that when they go into hospitals and look to see what hospitals are doing. Regulations or laws, things like OSHA regulations, bloodborne pathogen standard, those are things they factor in very heavily. They also really look at the facility or system policies. And we're going to get into that and then we get to the top 10 list, that your policies are really, really important. And then standards and best practice was like the lowest level of something they look for. They're not really surveying specifically to, say, an AAMI standard or an AORN standard. They like those documents. They think that they're best practice, but that's not what they're surveying to. And so when you have your system policies, if they're too specific or if they reference, say, an AAMI standard, then they will bring those standards into account. But standards best practice, not something they look for as important as those things we listed above. So let's look at those facility policies because that's really going to be the important part of what we're talking about. First of all, who's referenced? And if you're talking about an AAMI standard or an AORN standard, they're going to factor that in very heavily. Then they're going to go to the standard to see what it says and whether you're following it. What do the policies say? So if you have your own facility policy on, say, soiled transport, and it lists a specific type of pre-cleaning fluid or pre-cleaning spray, and you're using a different one, well, then you're not following your policies. So make sure you read through those policies and kind of weed out anything that's too specific to the process. Now, you have procedures, and that's really important, but your policies are what they're going to survey. So we want to make those kind of generalized. And then when we get into our procedures or step-by-steps, those can be a little more granular. And then that's what the surveyors are looking for. Are you actually following what is written inside your policies? I was a manager at a facility where the policies hadn't been updated since the 1980s or 90s on some of these policies, and they had just been approved every 3 years. Somebody had gone through and given it a stamp of approval. If that's the case in your hospital, you really got to go back and look at what it says because it might be citing standards that no longer exist or a standard that's been updated since then. And so you got to make sure you look at those policies and procedures. I think that is the number one most important thing to prepare for a survey is looking at your policies because they're going to look at them when they come in. Objective 2 is illustrating the most common findings in SP and sterile and endoscopy departments. So in 2006, there wasn't as much of a focus on sterile processing and endoscopy. They came into those departments, but I remember I had a surveyor who, when they walked into sterile processing, said they had never actually seen one of them before. And we gave a little tour. They were there for maybe 20, 30 minutes. They didn't really look much at our processes, more at our workflow and how everything worked. But 2024, 2025, this is very likely the first place the surveyor is going to want to look at So they really want to know what is going on in sterile processing and endoscopy. I'm guessing they're probably going to look at your immediate use. That's one of the first things they want to look for. And with endoscopy, they want to see your process. Is there delayed reprocessing steps? Are you documenting the time that pre-cleaning is occurring? All of those things are really, really important to have in place because I guarantee you on day 1 or 2, they will be in sterile processing and endoscopy. It's low-hanging fruit and an easy place for them to get some findings. So let's look at some examples of some recent survey findings. This is based on a webinar that I did last year, and then I updated it this year with some of the 2025 findings as well. So the number 2 thing I think is documentation. When a surveyor comes into a sterile processing department, again, they're not sterile processing techs. They haven't grown up in sterile processing. They might have some experience. They may have worked down there. I know some of the surveyors have been in the military, where if you're a scrub tech, you also have experience with cleaning and sterilizing surgical instruments. So they will have some experience, but they're not going to be the type of experts that we would typically see in the sterile processing industry itself. So your documentation becomes really paramount. And specifically, if you have open spaces on your documentation, that's another place where surveyors are going to want to look further into, where they said you want to avoid that investigation. That investigation comes if you have like a gap in some of your documentation. So this was a document that I used in an old facility of mine. We didn't have a tracking system, so we did all paper documentation, but there was a lot of open spaces. And I remember the surveyor looking at this and just started like poring over, are there supposed to be things filled in to some of these spaces? Like on our Bowie Dick, there was no contents for that load other than the Bowie Dick test. So there was just the square that had the Bowie Dick test in the center. There was a printout on the right-hand side, but not a lot of other information was filled in. So they really do look at that documentation, look at yours, see if there are gaps, things that you might have to explain. And I remember this is one of my only findings I ever got from Joint Commission as a manager. I had a tech that did the Bowie Dick test, marked it as pass on the file, but forgot to check the box that said pass. And of course, that's a ding in your documentation. So documentation, poring over it, really important. The other thing I'll say is you don't want to have months and months worth of documentation sitting out in a folder. When Joint Commission shows up, you should have it, maybe the last few days of documentation. If you can, take it out and put it in a file folder for the last week, that's incredible. But you don't want to have a lot of documentation for them to go through because, again, they're going to be looking for those gaps in that documentation. And it's easy for them to spot those when there's a missing section or something, the checkbox is not checked. It's going to be something that's going to be a finding. Kind of similarly, they're going to go to your immediate use. So my number 3 is immediate use steam sterilization. It's one of the first things they're going to look for because they really want to see, are you filling out the correct information? Is this IUSS being tracked to a patient? And are you documenting all the things you're supposed to be documenting with that documentation? So there's 3 things I think are really important with IUSS. First of all, that patient identifier. They want to know if you're doing something IUSS, can you track it to the patient that will be used on? You want to have the item that's being sterilized. Why? Bill, because one of the things they look for is, do you have a plan for improvement? Do you have a way to limit your IUSS or start to see a decrease in IUSS? And you do that by saying, okay, here, this instrument was IUSS'd in April. It was then IUSS'd again in May. So maybe we need to buy more of that item because it's being used over and over again. So make sure you're actually documenting the thing that's sterilized. This is one that often gets missed if the OR is the one that fills in the documentation because they're just so focused on putting the patient sticker. This is the load I'm running it on, and that's all I need to worry about. Then they forget, what's being sterilized. It is important. The reason for IUSS, just like with the item, is because you want to be able to start seeing a decrease in IUSS. So what is the reason? Did the doctor drop it? We don't have enough on hand. Whatever that reason is, make sure you have that reasoning and rationale in the documentation. Like I said, you want to have a plan in place for IUSS reduction. Make sure you're tracking the items that are sterilized and you have that list of items. track your IOSS loads, and then make sure you're reducing the percentage over time. So what you do is essentially you look at the total number of cases that the OR does, the number of IUSS loads that are run, and then you divide the loads by the number of cases, and that's your percentage. So you want to reduce that percentage over time. Make sure that you're seeing that decrease, whether it's 5, 4, 3, whatever it is, that you're seeing a decrease over time. If you're going in the wrong direction, there's probably some efforts that you need to make. But as long as you're tracking it, that's what the surveyors really want to see. Okay, I'm tracking it. We have a plan for reduction. Maybe it's high right now when they come in. But if you have a plan and you can show that you're reducing it over time, that's what they're looking for. My number 4 is endoscopy. Just like with the IOSS, it's one of the first things a surveyor is going to want to see when they come in. They're going to want to see those flexible endoscopes because national patient safety goals, it almost always shows up in the top 5. We have a lot of infections associated with damaged or improperly inspected endoscopes. We've seen outbreaks with the water lines coming into the AER. So a lot of issues with endoscopes, and they are going to be looking at that area very heavily. Before they come in for survey, check your scope IFUs and make sure that staff can access those IFUs as well. That's what the surveyors are going to want to know. Look at this specific model of scope. Do you have the IFU and are you following it? With that, you're going to have your AER or your disinfectant IFU, as well as your sterilization instructions for use. You want to make sure you've got all of that documentation that you can show them. Yes, we have it. Yes, we're following it. And when they observe a technician, they used to sort of just say, hey, what are you doing here? What are you cleaning? Things like that. Now they will actually look up an IFU and then watch the technician to see if they are following step by step that IFU. So it's really important when a surveyor is in place or comes into your facility that you've got those instructions for use easily accessible. Remember your policies and procedures. And just like I said earlier, who's referenced? Are you looking at AAMI standards and referencing that in your policies? What do those policies actually say you're supposed to be doing? And are you following letter by letter what's in your policies? There's 3 areas I think you should look out for in endoscopy. First of all, they know about the leak tester pressure issue. In the old days, we used to have the leak tester hose, and we would take our finger and we go, pss, pss. And if we heard that sound, then our leak tester was good. But that's not an acceptable test. That's just sort of up for interpretation. We don't know when that sound is good and not good. So now you actually do need to measure your PSI. Make sure you have a way to test your leak tester pressure. Now, the newer machines, if you have one of these new ones that's more computerized, they actually do have a self-test functionality. But if you have one of the older ones, the Olympus MU1 or one of those older units, make sure you have, or even the handheld pumps, if you have one of those leak testers, make sure you have a way to test the pressure output from those. It's an important step that's getting missed, and I see it getting findings in facilities. Your high-risk endoscopes, the standards changed in 2021, 2022 when the new ST91 document came out. So your high-risk endoscopes, duodenoscopes, EBUS all those kinds of things that are high risk, you do need to do cleaning verification testing every time. And that is a shall statement in the AAMI standards, which means if you're referencing AAMI standards in your policies, you need to be following what it says in the standards for high-risk endoscopes. So make sure there's cleaning verification testing on those high-risk scopes. Another thing that changed was the 10 minutes of forced air dry. A lot of people think, well, I don't have to do that because it's going to hang in the cabinet. No, it's still a required step before it goes into the cabinet, that 10 minutes of forced air dry. The reasoning is because a lot of people were getting droplets that were stuck inside the scopes. And because of how small the channels are, it's very difficult for that drip drying or for gravity to work on them. So the scopes were just staying moist inside. And of course, anywhere where you have a dark, damp environment, you're going to have microorganism growth. So a lot of these outbreaks that we were seeing from endoscopes had probably some kind of connection to the fact that these scopes were hung wet. So make sure you're doing that 10 minutes of forced air dry. Now, if you have a drying cabinet that does continuous drying, perfect, awesome. That's a great way to do it. But still make sure you're doing that 10 minutes of forced air dry after you do the cleaning steps and after the disinfection steps. So training and competencies, I think, is a really big part of what they're going to be looking for survey time. making sure you have a detailed list of tasks that the technicians need to complete for training, and then make sure they're signed off. And then remember that your competencies also need to be updated year after year. Some things you want to look for with your training and competencies, again, make sure it's upon hire or anytime there's a position change. Make sure you're doing it yearly. And anytime you get a new device or a new piece of equipment, make sure you update those competencies as well. This is why educator positions are so important and why we're seeing them come into play in departments now in the modern day of sterile processing, is because this is a lot of documentation to keep up on. A manager can't be running the department and worrying about all these training and competencies all the time. It's just not possible. So that's why the educator position is such an important one in a sterile processing department. As far as what goes in your competencies, make sure you have required knowledge like, say, OSHA bloodborne pathogen standard, worker safety, PPE requirements, all those kinds of things. The required skills, that's the skills needed to perform in the position. Do they know how to wrap a tray? Do they know how to test their insulation? Do they know how to I don't know, use the borescope to inspect the things that are required to by department policies? It's really important to have all of the different skills and make sure there's a competency for them. You should also have one for each machine. And a lot of times the manufacturers will come in and help you with these. Either they have a competency document or they'll actually run through those competencies with your staff. But make sure that every single machine they're going to be using, there's a competency for it. And then department specific ones are like, hey, if you have robotics in your department, you should have a robotic competency so that they know specifically how to do those. Or if there's an AER, that's another one that's specific to some departments that others might not have. But make sure that you have all of those kinds of documentation for competencies and training. Number 6 is instrument tape. And instrument tape is always a complicated issue. I know that departments want to keep sets together and instruments together, grouped together, but this is one that surveyors have really pinpointed as an easy visual indicator. Again, when a surveyor comes in, they're not a sterile processing quote unquote expert like a lot of people in the industry are. They have a certain amount of knowledge, but they're looking visually for things they can see, like gaps in documentation. Just like that, instrument tape is a bright, shining indicator that there may be further issues. So if they see indicator or instrument tape, they're going to be looking more into your processes and probably opening sets to see, is there a tape problem? Is there broken tape, missing tape, or pieces missing of it? First of all, can you use it? Yes. The standards say that you can use instrument tape, and they even give guidelines. Make sure you're looking at the manufacturer IFU, but they give guidelines on guidance on how you're supposed to be using instrument tape. So the reason it becomes an issue is because, are you using it the right way? Do you have it intact? Does it look like it's brand new, or is it old and discolored? And if it's old and discolored, it will prompt the question, when was this put on? Then they'll look at the IFU for the instrument tape. How often is it supposed to be replaced? Well, if there's any discoloration, or maybe it's supposed to be replaced every year, in which case it's really tough to get instrument tape, managed. So what I did in my facility was we had our repair vendor that came in, and every year we had a certain list of sets that were taped, and they had to replace that tape every year. And then at the technician level, if they noticed any tape kind of discoloration or cracking or breaking, remember, these things are going into an autoclave. It's going to get hot, it's going to get wet, and then it's going to get very, very dry. So it's an easy way for this tape to dry out and start to crack or break. That's where you see flaking. Just make sure that your techs know to replace it if it gets to that point. So again, we had our tape replacement every year, and then we had our techs really focus on looking at it. And I'll let you know, we still got dinged for a tiny piece of tape that was broken and missing from a set. Because again, when it's missing and they can't see this little flake of tape, could it be in a patient? We don't really know. So my advice, get rid of it if you can. If you're able to just remove all instrument tape, great. But they will also accept if you have plans for replacement and things like that. If you have tape, make sure it's properly applied. That's a big issue where they just wrap it 3, 4, 5 times. It should be 1.5 times that it's wrapped around the set or the shank of the instrument. Is it flaking or damaged? And is it discolored, or is there residue? So if they see any kind of like dark spots on the tape, that's another red flag that there's some kind of residue on it, and it probably should be replaced. Here's just some pictures of instrument tape and some issues, and you can kind of see there, you can see there's like overlap or gaps, and anywhere we have gaps in the tape or pieces missing, that's a place where microorganisms can get in, and they're going to love being in that dark environment inside where that adhesive is. So make sure that it's just going 1.5 times around and that it's nice and cleanly sealed off. Here's another one where you could just see it's starting to crack. It's discolored. It's having issues. Same thing here where it's actually peeling up and you can see the areas peeling. Even in the box where you have the extra instruments, this is another area that they like to go to because again, there's tape there and you can see on the screen kind of right there at the bottom, you can see that there's that blue piece and then a big nasty sticky piece of adhesive that's left there or discoloration or residue. Imagine the biofilm that is living and thriving inside of that adhesive. It's a perfect place for them to grow and thrive. So my advice, just get rid of the tape altogether. Number 7, peel pouches. Peel pouches are another area where I think we've got a good handle on how these things work. And you probably do. You probably have a good handle on the actual process of peel pouching, the skill of pouching a peel pouch. But we have issues with our seals. We have issues with storage. There's a lot of things that can go wrong. My colleague, Melinda Elamari, the packaging princess, would absolutely agree with me. Peel pouches are something that surveyors are focusing on because they can spot the issues very easily visually. If you're double pouching, make sure that you have the same manufacturer and that manufacturer has a statement in their IFU that states that it's okay to double pouch. Surveyors have picked up on the fact that a lot of hospitals use multiple vendors for pouches. And when you're putting manufacturer A inside pouch manufacturer B and you put them together double pouching, no one has tested that. There is no testing data that says that's okay. So you have to make sure it's the same manufacturer and that manufacturer has a statement on double pouching. There are major manufacturers, and it's something that we've dealt with when I was a manager, and I've seen it in the facilities in the last year or two. They're getting dinged because there's no statement on double pouching in the instructions for use. You should never fold a pouch to fit it inside another pouch. You should never fold it to put it away because it doesn't fit in a bin, for example. Folding pouches is a no-no, and especially for sterilization. Remember, you have a paper side and you have a plastic side. That paper side is where the sterilant is going to get inside and it's going to contact the surface of the instrument. If you fold it back over, now there's a gap in a place where that sterilant can't get in. So folding pouches is an absolute no-no. And then damaged seals, and I hope we have some pictures on the upcoming slides here of some damaged seals. It's another one that surveyors actually go into sterile storage, start pulling pouches, and then they examine the seals on them because we just don't pay enough attention to when things are damaged. So here we have a folded pouch. And again, it looks like there might be 2 different manufacturers. Oh, maybe it's the same one, but you could definitely see it's folded over. It doesn't quite fit. And that's how they've managed to do it, is just by folding it over. This is another one that you could see that there's issues with the folding or how it's going to fit inside. It's very crinkled. It's starting to bend at the edges there. This is a wrap inside of a peel pouch. So a wrap is a form of a sterile barrier that has its own instructions for use. A peel pouch is another sterile barrier that has its own IFUs. And you cannot put one of these inside of the other. You shouldn't put a wrap inside of a rigid container. You shouldn't put a rigid container inside of a peel pouch. These things are individually have their own IFUs. Don't mix and match them. They're not plug and play or mix and match. This one is a self-seal pouch that's not folded correctly. And my old colleague, Seth Hendy, I love what he used to do because he used to actually take these pouches that were folded incorrectly, these self-seal pouches, and when you blow inside of them, it will blow the pouch up. And guess what? If that air can get in and it can blow the pouch up, then that's a place where microorganisms can get in too. So your self-seal pouches, this is one surveyors have picked up on. If they're not perfectly sealed across that opening so that there is an airtight barrier, then that's not an acceptable pouch. And surveyors do find those things very quickly and easily on a cursory search. I find them as an auditor as well. When I come into hospitals, I see that in the peel pouching area. So you better be confident that your seals are good when that surveyor walks in the door. there's that hole, and that's a better idea, a better picture of the hole where you can actually see that there's a gap there, and then it's just not sealed across all the way. What we recommend with our self-seal pouches, and I would recommend you do this in your departments, is take your thumbs and put them in the center of the pouch where that seal area is, and go across 3 times, pressing that area down. So you want to make sure that it has that nice clean seal and no air and no microorganisms can get in. We also have issues with our heat sealers, and you can see here, this is a heat sealer that has damage to it. The heat sealers, especially those bar ones where you lift it up and then it goes and then falls down, those have it's like a rolling mechanism inside that has to be rotated, because eventually if you heat that same spot over and over and over again, eventually it will start to get worn out. There will start to be pieces missing. And you can see in this slide, hopefully you're able to see it clearly enough, that there's gaps in that heat seal. And then when you look inside the heat sealer, sometimes you're going to see damage like this, where that same spot has been used over and over and over again. And now you have gaps in the heat sealer. Now there's a burnt indicator as well, which means there was some other issues going on with this heat sealer, but the damage you saw previously was because that heat sealer bar was not being rotated. So if you have that bar heat sealer, I can't remember if it's monthly. I want to say it's every month you're supposed to be rotating it, but just make sure you're looking at it and making sure that your seals are in good shape. There are tests as well. So there are peel pouch tests, and you can see here the ink is starting to leak through the pouch. A perfect sign that your heat sealer is probably not working the way it's supposed to, because it should be, again, an airtight seal. Don't use pouches. And again, this is Melinda's pet peeve in sterile processing. Don't use pouches for anything other than peel pouching instruments. I know they're kind of a convenient storage location. So we have these peel pouches all over the department that are holding things. That's not what they're for. And again, surveyor, when they see something like this, will say, well, how do you know that that pouch won't be used later on? And we don't really have a good answer other than, well, we'll try to use common sense, but we don't have a way to know that this pouch won't be sterilized and put up on a case. So only use your pouches for what they're supposed to be used for, which is peel pouching and sterilization. This one bothers me, brushes on the prep side, because I hear people say, well, we have no other way to verify that something is clean unless we take a brush and brush it on the prep side. Think about what a brush is. It is a cleaning implement. It is for cleaning a device, or let's even take the example of brushing your teeth. Nobody says when they're brushing their teeth, oh, I'm just verifying my teeth are clean. No, you're using it to clean your teeth. That's what a toothbrush is. And the brushes on the prep side are the same thing. You're just brushing it because you're trying to clean off whatever might be on there. And this goes for channel brushes. This goes for toothbrushes. Anytime there are brushes on the prep side, cleaning should be done in decontamination, and it is a red flag to surveyors to start investigating further when they see them in prep, because they know, well, things are not getting done correctly in decon. People are nervous, and so they're starting to use these brushes on the prep side. And go into if you're a manager and educator, go into the drawers, go into the hidey holes in the department, because you may have technicians that are hiding these they'll be found during survey time, unfortunately. But this is one that really bothers me with the brushes on the prep side, because I've heard vendors say, oh no, it's totally fine, it's just an inspection brush. Well, the surveyors, what their response to that is, well, how do you know that this brush hasn't been used in decon? Usually we have no idea how to answer that. And how do you know that this won't be used in decon? How do you know the difference between an inspection brush and another kind of brush? And again, just goes back to my main point, which is a brush is used for cleaning. It is not a verification tool. These, again, I see them everywhere in almost every department I go into still. And it's just sort of, well, it's just in case. It's just to check the lumens, or, it's just to, verify that these things were cleaned correctly. No, stop it. Put it back in decontam where it's supposed to be. And let's just keep the brushes and the cleaning stuff in the dirty side of the department. Expiration dates, another low-hanging fruit, and I don't want to get too deep into expiration dates and why it's important, but this is one, again, a surveyor comes in, they're visually looking at our stuff, and the dates are a very easy indicator that things are expired. Look at your pouches. Now, pouches, when you remove them from the box, Some pouches don't have an expiration date or a manufacturer date on the pouch itself. So you have to have some way to track when do these pouches expire. My recommendation is to keep it in the box or find a manufacturer that actually has the expiration date on the individual pouches. Some of them do. They're probably the ones that are a little more expensive because that kind of foresight usually means there's more expense involved. But the pouches and the expiration dates are one that's very easy for them to spot. If it's not in a box, then they'll say, when do these expire? And if you can't answer, there's a finding. The disposables like locks and indicators, especially if they're those color change locks and indicators, those should have an expiration date. And if you dump them out of their packaging or their box, a lot of them do not have expiration dates on the indicators themselves. Now, the indicators, like the class 5 integrating indicators, some of those will have the dates on the back side where they'll actually have the expiration date or the manufacturer date on it. But a lot of the locks and those kinds of things don't. So if you're dumping them into a secondary container, make sure that you keep the right lot number and that box or that container or that whatever it is that you're using to hold it is labeled with the correct expiration date, and make sure that you have some type of documentation that shows that you are looking at those things and changing that out when needed. Isopropyl alcohol is another one I see very often, that there's just a loose bottle of isopropyl alcohol in the department. It's again a red flag, just like with the brushes. It's a red flag that maybe we need to look at their process a little bit. Why are they using the isopropyl alcohol? Are they using it on instruments? Why are they using it on instruments? So it just prompts a lot more investigation and a lot more questions. My advice, don't put isopropyl alcohol in the department. And if you do, make sure it has expiration dates and make sure you have a specific use for it. For example, we only use it to clean our keyboard or our mouse or whatever it is. We do not use it for any other purpose, and we don't use it on instruments. Usually they will accept that, but the expiration date is another big part of that. On the event-related sterility, make sure that you have a policy that says what event-related sterility is. You can't just leave a package on the shelf forever and assume that it's going to be in good shape. There has to be some type of language around what an event is. Now, remember, there's a couple things to think about. With expiration dates, the expiration date of a product before it's sterilized can be an event. So you have to address that. If you have an expired product and you're sterilizing it, now essentially you shouldn't be using expired product. Same thing with like post sterilization. Most manufacturers have some kind of statement that says we use event related sterility. And then if you ask and go into that further, they do have other things, like they've only tested it for 6 months on the shelf or 1 year on the shelf. So they've done this shelf life testing. You should have a multidisciplinary committee, IP, risk management, that goes through your policies and looks at those kinds of things. But don't just assume, oh, we have an event related policy, that thing can stay on the shelf forever. Look at those statements about shelf life and how much they've actually tested for, and then determine, write that into your policy that we've taken this into consideration. Here's what our multidisciplinary risk assessment was, and this is what we decided at our hospital. But you're going to be surveyed to the standard that you set in your policy. So if you say event related with no qualifications to it, they're going to see that and then start looking further at, well, what does the IFU say? When do these things expire pre-sterilization? What is their shelf life testing post-sterilization look like? And then they'll examine whether or not you're actually following what's set in your policies. Expiration dates on wrap, peel pouches, rigid container filters. A lot of those only have like a 6-month or 1 year expiration dates on them. Then shelf life testing, look at that shelf life testing and really start to see how long can they realistically stay on the shelf. And if you're going to go past that date, that's totally up to the facility if you want to go past what the manufacturer has tested for. But I would recommend you do a risk assessment and say, look, we're going to go to 2 years or 3 years beyond what the manufacturer says because we've done a risk assessment and here's the data we're using to justify it. Surveyors are good with that, but if you don't mention it at all, that's usually something that they're going to investigate more into. So just like we talked about, we're going to demonstrate some scenarios that are going to prompt more investigation by surveyors. And that's going to bring us to number 10 and our last thing we're going to look at here, the environment and the environment of care. There's a special surveyor that just goes around looking into the environment. And what that means is they're going to be looking at the airflow patterns. They're going to be looking at whether doorways are changing the airflow patterns. They're also going to be looking at your walls and your floors and your storage areas to see what kind of issues they can find. And if they see a shelf that looks like this, you can bet they're going to be in there a long time looking at the environment of care. This is one that should be taken care of immediately. And I know when we're in a department, it can be tough to see these kinds of things that are happening. First of all, cork should never be in a sterile processing area at all. But broken cork is a red flag that this issue has not been addressed, or divots in the floor, cracks in the floor where things can start growing up out of. This was an issue that a surveyor actually cited a hospital for, and then they sent it to us. So I'm not going to list the name of the hospital or anything like that, but you can see that there are multiple issues in this picture, cracking paint and things like that. But what the specific issue was there was an electronic connector right next to where the spray arm was, and they deemed it to be an electronic risk. Now, it wasn't a finding, but it was a risk factor that there was some kind of issue with this electronic cord that was right next to where the spray was. But just multiple issues in this picture that you can see with this type of sink setup. This was a decontamination area, and you can see that there is a door from the decontamination area into the break room. And this is an audit that we came in and did at Healthmark. But when we came in, we saw that you could see right into the break room from the decontamination area. Pretty clear red flag that we've got some airflow issues going on here and that there's risk of contamination. I also wouldn't want to eat in that break room. Here's another one where you have sealed wraps and peel pouches inside of an area with unsterile items. So that's not, and a lot of departments have like this storage area inside the department where these old sets live. If it's in a sealed container or package, surveyors will see that as patient ready. It doesn't matter what you think it is. It just matters, does it look like it's patient ready? And the concern is that these packages that have now been contaminated with, say, a towel or all these other things, wooden shelves they're sitting on, are now contaminated and could be used on a patient. So look at those areas where sets conglomerate. Make sure you're removing everything from the pouch, the wrap, the rigid container before you put it onto a storage shelf where it's going to sit probably for the next 10 to 15 years like they did in our departments. But make sure you look at those kinds of things as well. Hanging pouches is one, and this one you can specifically see is there's a hole right through the seal to the pouch. That's not acceptable. And hanging pouches are also problematic because the pouches were validated in a specific way. Usually what the manufacturer IFU says is sitting on their side so that they're, the sterilant can get in and penetrate. Remember, the pressure changes, so it's going to blow up like a balloon and it'll constrict and all that air and sterilant will be removed. But if you vertically hang it, that's not something that the manufacturer has tested. You're putting a lot of weight at the top or bottom of that peel pouch, and maybe it can't handle that in that specific way. They've been validated for a specific setup. Make sure you look at your IFUs and see what the manufacturer recommends before you do anything like vertical hanging. My advice is I wouldn't do it, just because surveyors are seeing it now, and they're looking, first of all, at the holes and seeing what kind of things are being done there, but they're also looking at what does the IFU say about peel pouch storage. I showed this picture earlier in the slides, but you can see there are wrapped items that have been sterilized. You can see the tape, you can see peel pouches, rigid containers. All of those things are things surveyors are going to ask more questions about. Another easy one, PPE. If you see somebody not wearing their PPE correctly, especially if surveyors are there, but regardless of whether there's a surveyor there, this is dangerous. This is something that could cause infections in our staff. We have OSHA bloodborne pathogen standards that say we need to have the right PPE, and as workers, we need to be wearing that PPE appropriately. This is an emergency eye wash, and hopefully you can spot that there's some issues here. First of all, it's connected to a decontamination sink. That's not a good place for an eye wash because there's dirty stuff all over that area. You could also see that there is an end cap, or the cap to the eye wash is missing and it's off, which means that whatever you were cleaning in the sink, there's droplets that are now inside that eye wash, and that eye wash is going to go, and if there's an emergency, somebody's going to have that in their eyes. This is a bad situation. So check your emergency eye wash. And again, the environmental person, They look at the airflow probably first, but the eye wash is really like either one or two. It's like first or second thing they look at when they come into the department. So check your eye wash station as well. You're transporting from the decontaminate, or sorry, from OR to decontamination. Examine that process. OSHA has specific recommendations on how things are transported throughout the hospital. And this was actually in a patient hallway where patients were coming through. This is not an acceptable way to take dirty things from the OR room to decontamination. They have to have some type of container system or sealed system so that it's leak proof, puncture resistant, all those kinds of things. Just wrapping an OR or a wrap over the table is not a system of soiled instrument transport. Solutions for all of these issues that we covered today: rounding. And my old colleague, John Whalen, turned me on to this GEMBA, go to the actual place, is what that means. That's a lean processing terminology of GEMBA, or go to the actual place. Don't just assume because you've set a policy in place that the staff is always following it every time. Actually go look and see what they're doing. Create an audit tool or modify an existing template. There's lots of auditing tools online, or you could have somebody like Healthmark help you to build an audit tool. And you want to do this on a regular basis. Don't just do it once a year. Really try to do it, I would say, monthly or quarterly, where you're actually going to the actual department and doing this audit just like a surveyor would. So my biggest pet peeve when I go into hospitals, I say, well, how do you access IFUs? And almost always what they say is, oh, we have OneSource. Perfect. That's great. I'm glad you have OneSource. That's a great tool if you're using it effectively. But show me the IFU for this arthroscopic shaver. I have this arthroscopic shaver in my hand. I want to see the IFUs for it. And then all of a sudden there's like this, the wheels start turning for the technician where, oh, okay, how do I access OneSource? I think that I have a login. Is there login information? I don't remember what the login information is. Okay, I got to look up and figure out how to get login. And I'm not going to go through the whole thing. It's this long process of they haven't accessed OneSource probably since they were initially shown how to use it. And it's very evident they've never been in there to see it. It's complicated. You have now multiple modules. So you have instrument modules, they have dental modules, they have endoscopy modules, all kind of different modules. So you have to select the right one, and then you have to put in your part number or the really good description of what it is, the manufacturer, and then you have to pull up the IFU, and then there's multiple buttons that you would have to figure out which one is my actual correct IFU. So one of my biggest pet peeves is we have OneSource, but staff doesn't know how to access it. When a surveyor comes in, they had better be prepared that they can very quickly look up the IFU in OneSource. Hopefully your tracking system helps you out where there's an actual button links to it, and that they're able to log in, find the right module, find the right instrument, and everything goes smoothly. But that is really my biggest pet peeve, is that staff cannot access the IFUs, even though they have a tool that will help them do that. So see it like a surveyor. Just think of yourself as somebody who's surveying your department. So just see any sterile processing or endoscopy department, not your department. See it on a department that you're going to go survey, and then bring in fresh eyes. Get your IP, your risk management, your safety to come in and help you do these audits. And you can have a checklist of things they need to look for. Your vendor partners like Healthmark can come in and actually do like audits and look at specific parts of your process. And during those surveys and audits, make sure that they're asking questions. Don't just check boxes. Make sure that you say, hey, can you walk me through how you're cleaning this flexible scope? How do you know what steps you're supposed to be doing? And then make sure they're writing down the answers. Because a lot of times if it's somebody they know, they'll be more honest and they'll say things like, well, I just, we do the same thing for all flexible scopes. That would be a red flag to a surveyor that, the IFU for this one, is it actually being followed, or are they just doing what they think the right process is for a flexible scope? So those are the kinds of questions they need to be asking. How do you do this? Why do you do it this way? All those kinds of things. So here are my references. Thank you for sticking with me through this top 10 list of issues that we can look for during surveys. Here is my contact information. I've got a QR code there where you can add me on LinkedIn. Remember that if you want CE credit for this presentation, make sure you head over to academy.hmark.com. That is the Healthmark Academy page where you will get your CE credits. And if you're HSPA certified, those CE credits that you earn on Healthmark Academy are automatically sent to HSPA and applied to your account. It is such an easy process. You just do the education, it's automatically sent and applied. When I went to re-certify last year, all of my stuff was already in the system, and I didn't have to upload certificates or any of that stuff. It was a very easy process. So thank you for watching, and thank you for everything you do in sterile processing. I hope you have a great SP Week 2025. And if you're watching this in the future, hope you're having a great day no matter where you are.